Shall we start, Samir?
Yes, yes.
Onychomycosis, okay.
Good morning. Today I am going to present about onychomycosis, which is a fungal infection of the nails. Onychomycosis, also known as tinea ongium, also is a fungal infection of the toenails and fingernails that may involve any component of the nail unit, including the matrix, bed, or plate. Onychomycosis can cause several complications like pain, discomfort, disfigurement, and may produce serious physical and occupational limitations, as well as reducing quality of life. There are different types of onychomycosis. First one is distal lateral sublingual onychomycosis, ELSO, which is the most common one, followed by white superficial onychomycosis, WSO, and proximal sublingual onychomycosis, PSO, endonyx onychomycosis, EO, and candidal onychomycosis. Patient may have combination of this type. Total dystrophic onychomycosis refers to most advanced form of any subtype. A skin injury adjacent to the nail may allow organism to colonize, thereby increasing the risk of infectious complication. Onychomycosis can be seen in immunocompromised patients, and it can cause increased severity and mobility of the patient. Diabetic foot also is a serious complication associated with the onychomycosis. In early years, it can cause different kinds of complications like poor vision, arthritis that prevent optimal foot care. In distal lateral sublingual onychomycosis, as I mentioned, is the most common form of onychomycosis. The fungus is spread from plantar skin and invades the nail bed via the hypokine. Inflammation occurring in these areas of the nail apparatus causes the typical physical signs of distal lateral sublingual onychomycosis. Endonous onychomycosis is a variant of distal lateral sublingual onychomycosis in which fungi infect the nail via the skin and directly invade the nail plate. Okay, coming to etiology, there are three main classes of fungi which are affecting, and they are the causative organisms: dermatophytes, yeast, and non-dermatophytes molds. And among dermatophytes, 90% of the cases of onychomycosis is caused by organism which we are calling as Trichophyton rubrum. It's about 70% of the cases, followed by Trichophyton mentagrophyte, which is account for 20% of the cases. White superficial onychomycosis is usually caused by Tinea mentrophytus, and non-dermatophytes molds cause deep white superficial onychomycosis. Risk factors for onychomycosis including family history, as we know, it can be spread from to people to any. It's a kind of contamination disease, and also family history can be a risk factor. Increasing age and poor health, as we know, in immunocompromised patient, it can be a population which is more prone to develop this disease. Prior trauma and then warm climate, participation in fitness activities, immunosuppression like HIV and drug-induced, and communal bathing and occlusive footwear. These are the risk factors for developing onychomycosis. In epidemiology, half of the nail disorder, onychomycosis accounts for half of the nail disorders, and is a main nail disorder in the adults. And then toenails also is more effective, is more prone to develop this disease in that area compared to fingernails. As we know, they are more in moisturized area, and then uh, most of the time they are in the shoes. That that can be a reason for that. Onychomycosis affects person of all races. And then males also are more common, it's more commonly in males compared to the females. And then studies indicates that adults are 30 times more likely to have onychomycosis than children. Onychomycosis has been reported to occur in 2.6% of children younger than 80 years, but as many as 90% of elders. Coming to diagnosis, there are different methods for the diagnosis of the onychomycosis, and then there are some they are not that much precise. For direct microscopy, it can be negative up to 10% of the cases, and in culture, it can be negative up to 30% of the cases. What is direct microscopy? It's a very common and usual method for finding to rule out that whether the fungi is present in that area or not. It can be also for other types of the tiny infections. Here we use the 20% potassium hydroxide KOH preparation in dimethyl sulfoxide, the useful screening test to rule out the presence of fungi. And then before obtaining a specimen, the nails must be clipped and cleansed and alcohol swab to remove bacteria and debris. Nail fragments must be small enough to examination under low power. Large pieces of nail plate may be pulverized prior to microscopy by using a hammer and nail micronizer. Contrastains such as chlorazole black E or Parker blue black ink may be used to accentuate the hyphae for the surrounding part of the fungus under the microscope. Second one is culture. In culture, we will understand which organism which is affected for the developing of this disease. And then, but as I mentioned, it can be negative in 30% of cases. So we are not that much going to do this because anyhow, it's very, it's not that much precise. And then other test also is polymerase chain reaction, PCR, which is assays for developed to detect fungal DNA from infected nails. The other test. In histological findings, examination of nail is very useful alternative to culture or KOH testing. Nail clipping may be sent to the laboratory for diagnosis in a formalin-filled container, or as a last resort, an incisional nail biopsy may be performed to help confirm the diagnosis. Staining in laboratory should be performed with a periodic acid skip stain, PAS, or methenamine silver stain to reveal fungal elements. The comparison of diagnostic methods revealed that the nail biopsy and staining with PAS is the most sensitive technique available to diagnose onychomycosis. So these are the diagnosis methods. Coming to a staging, newly they have developed a severity index, which we are calling as OSI. And it's recently been proposed to grade the severity of the distal sublingual onychomycosis. The OSI score is obtained by multiplying the score for the area of involvement, range from 0 to 5, by the score for the proximity of disease to matrix, range from 1 to 5. 10 points are added for the presence of longitudinal streaking or a patch or for greater than 2 millimeter of sublingual hyperkeratosis. So totally there will be a scores, and then for mild cases it will be from 1 to 5. For moderate cases it will be from 6 to 15, and severe for from 16 to 75. These are the staging severity index, which is helping us to know how severe is the infection. Okay, coming to treatment part, as we know, onychomycosis is a fungus disease, so we have to go to antifungals. In clinical trials, which has been developed, there are some controversial uh, or medications for the treatment of onychomycosis. In a meta-analysis of 18 studies on terbinafine, 16 studies on pulse itraconazole, and 3 studies on fluconazole for onychomycosis showed a mycological cure rate of 76, 63%, and 48% respectively. So it's showing that terbinafine is a agent which is very effective, followed by itraconazole. Treatment of onychomycosis depends on clinical type of the onychomycosis, the number of affected nails, and severity of the nail involvement. We have 2 options for the treatment, both systemic and topical, but as topical agents are very poor in penetrating to the nail bed and matrix, so our first choice is systemic treatment. And then to avoid the recurrence of the disease, because it's a disease which is required recurrence rate is so high. So we have to go for systemic agents, which they will be present in the nails for longer period of time. But for those patients which we are not able to give the systemic medications, because maybe they are not able to tolerate the systemic treatments, or maybe they have other problems, we have to go for topical agents. Topical treatments alone are generally unable to cure the onychomycosis, but insufficient nail plate penetration because of that. Cyclopyrox and amorphine solutions have been reported to penetrate through all nail layers, but have low efficacy when used as monotherapy. Efinaconazole is an agent which is indicated for toenail onychomycosis based on the two phase 3 multicenter randomized trial in 1,655 cases. It has shown 17.8 and 15.2% of the cure, and then this is versus 3.3 and 5.5 of subject receiving the vehicle, or we call it as placebo. Taboborol is a topical oxaborol antifungal which is containing boron. Is indicated for onychomycosis of toenail due to Trichophyton rugorum and Trichophyton mentacrophytes. Coming to oral therapy, as I mentioned, we have to go for some famous antifungals like itraconazole, terbinafine, and fluconazole. And then fluconazole, and then new triazole, call it as posaconazole also, it can be effective, but they are not approved by the FDA. We also have another option of surgical care. Several laser devices have been used to treat onychomycosis, including ND, YAG lasers and diode lasers. Evidence-based data on the efficacy of different lasers are still poor. Laser treatment can be combined with topical antifungals. They can be used together. Surgical approaches to onychomycosis treatment can also include the mechanical, chemical, and surgical nail ablation. Chemical removal by using a 40 to 50% urea compound is painless and useful in patients with very thick nails. Removal of nail plate should be considered an adjunctive treatment in patients undergoing oral therapy. The combination of oral, topical, and surgical therapy can increase efficacy and reduce the cost. Okay, there is a guideline for the treatment of the onychomycosis, which is developed by British Association of Dermatologists in 2014. For adult, systemic treatment recommendations are as follows. Terbinafine as first line of treatment for dermatophyte onychomycosis and generally preferred over itraconazole. Not recommended for patients with active or chronic liver disease. Itraconazole as a first line of treatment for dermatophytosis onychomycosis also is another option. Fluconazole can be alternative medication, and cryzophalvin also is another option, but due to high relapse rate, it is not used anymore. Combination of treatment recommended if response to topical monotherapy is likely to be poor. For adult, topical treatment recommendations are as follows. First line treatment is amorphine and ticonazole, are useful for superficial and distal onychomycosis, which are kind of rare, which are kind of the mild forms of the disease. Cyclopyrax is useful for superficial and distal onychomycosis and for patients in whom systemic therapy are contraindicated. Adult other treatment recommendations are as follows. Surgical ablution, debridement alone, and phytodynamic therapy not recommended. Children's systemic treatment also as follows. Terbinafine, it can be as first line like in adults, followed by itraconazole, and fluconazole also is the second line, and cryzophalvin considered as a second line if itraconazole and terbinafine are contraindicated or not tolerated. So we can see that cryzophalvin is using in children. Here is an overview of some treatment which are using very commonly for the onychomycosis. Terbinafine 250 mg daily for 12 weeks. Mycological rate cure rate is 71 to 89%. And also we have another option of the treatment, which is pulse therapy, which we are giving the treatment for 1 week and then we will stop it. And again, after 1 month, we will continue the therapy for 1 week. And again, we will continue it till 12 weeks in this disease. It is 500 mg daily for 1 week per month for 12 weeks. So we have to continue the treatments like 1 year. But only 12 weeks patient have been taken the treatment. So it will, this methods of the treatment can cause reduction in the complication of the treatment. So and then the medication also will be remain in the nails for longer period of time. The mycological cure rate is 59%, so it is a bit less than normal way of the treatment. There are different kinds of ADRs like rash, diarrhea, dyspepsia, elevation of the liver enzyme, and then it is also contraindicated in liver disease and renal impairments. And then it's a category B for the pregnancy. Itraconazole is another option with 200 mg daily for up to 48 weeks. Mycological cure rate of 46%, and for pulse therapy also we have 500 mg daily for 1 week per month for 16 weeks. It also has some ADRs like nausea, rash, vomiting, increase liver enzyme, and then it is also contraindicated in the hepatic impairment, and then it should be used with caution in patients with heart failure, concomitant use of CYP3A4 inducers, and also is a pregnancy category C. Fluconazole, which is second line therapy, is 150 mg weekly for 12 weeks, 51% cure rate, and also it has some common ADRs. It also has some common ADRs with the drug which are inducer of the CYP3A4, there should not be used, and also is a category D. For topical agent, also we have cyclopirox 8% applied daily with alcohol every 7 days for 48 weeks. Erythrema at application site, and it's FDA category B drug. Yeah, that's all. Thank you.
That's a good presentation, Samir. Onychomycosis, we had in PT2 fungal infection, we had red therapeutics too. But there we had red fungal infection in general, particularly onychomycosis was not there. And when it comes to the, like we had tinea infection, tinea cruris, tinea corporis, all those things we had read, but this is very closely, very similar. It's not that rare also, isn't that, Samir? It's not that rare also.
It's not that much rare, but compared
Yeah.
to that, diseases are rare. I have seen in the dermatology once only, after 1 year when I was there, once only I have seen.
Onychomycosis.
Yeah, one case is only I have seen.
But
very
generally,
rare
in case of
the
tinea corporis,
India, I think it can be rare in India, but maybe in other areas also.
what I was assuming is in case of patient who have like extensive tinea corporis, there is high chance that their nail also will get affected because corporis is throughout the body.
It can be, but you know, the penetration of the fungus to the nail is very difficult.
Yeah, and
you know, the
and it
condition
also
should be
depends
ready
on the,
for that.
yeah, it also depends on the like there are many predisposing factors like climate, the host factors, the yeah, as you told, the what are the favorable factors that makes the infection to happen. But when it comes to treatment, it's really, I think, tricky part, because we saw we have not much of new antifungal drug as you presented here. I think only one or two you saw to us. So and that too, we rely mostly on the older drug. Like we still some of the clinicians still use griseofil, which is like very old drug of fluconazole. Okay, these drugs are said to be like completely resistance. Okay, not these drugs are not not causing any kind of efficacy. Most of the organisms are resistant to these drugs, but still they rely on this drug. One of the effective drug that is like heavily used by clinician is itraconazole. Okay, and that again, when it comes to nail, we have to use at very high dose. The safety becomes the concern. Okay, the safety always becomes the concern when it comes to nail, because the drug have to penetrate into nail and have to give very high dose. And itraconazole is a drug which is not like the ADR, most of the general ADRs of the itraconazole. So
it's a high risk drug.
Pardon?
It's a high risk drug.
No, it's of a high risk drug. We cannot use a very it's not very elderly friendly drug. We cannot use in elderly with more of flexibility, even in pediatrics. How about pediatrics, using itraconazole in pediatrics, Samir?
Yeah, I mentioned in this guideline part. Yeah, it can they can use it for the actually the doses I have not seen, but this guideline they have mentioned the itraconazole.
Yeah, and this was one thing new that I was even not knowing. The guideline one of the guideline you showed now. Go back to that slide if you can. Was this? Yeah, British Assistant Dermatologist. So this is the new one actually, 2014 only you are telling now.
Yeah.
So we had American Academic Guideline, okay, and
That is for
someone
2000.
more
Yeah,
was
it's
there.
for long back, 90, I think.
Yeah, long back. That was in 1980, but this is something new that we are getting to know. So good. And in India, as you said, you haven't seen much, no, onychomycosis.
Actually,
Mm,
I remember that some clinicians was saying that because Indians are not using shoes in daily life,
oh, okay, okay, okay.
it can be preventive measure for that. But
Okay. Yeah.
anyhow, also it can be a rare fungus disease compared to others because very difficult
Mm,
to penetrate and
yeah.
devastate.
Rubrum cannot cause, no, this one, onychomycosis. Rubrum, tinea
Yeah,
rubrum, no?
I mentioned here that
No,
uh,
generally, what I'm thinking is this
organism I
thing,
mentioned, Trichophyton ruberum, is account for 70% of the cases.
70%, okay. Mhm. And rubrum is the one, no, which is causing corporis and cruris
Yeah,
most
yeah,
of the
it's the
time.
same one.
Mm,
Same.
yeah. Okay, so that was good presentation. Audience, if you have any question, clarification, we can have discussion. You can ask with Samir now. Anybody? Nobody have any questions?
No, sir.
Okay, so we'll close this presentation, Samir.
Okay, thank you, everyone.
And what's next? I think 15